So yeah, as a junior doctor, you'll see lots of patients with comorbidities, and they'll be going for surgery, and that is going to be a little bit tricky. So how do you know if they're safe for surgery? Now, that's a really complicated question. And I feel like a lot of people make this question far more complicated, and the answer seems more complicated than it is. And yeah, so what we're going to go through, all of this stuff in a simplified way, and when you should speak up if you think they're unsafe and need to be optimized as well. So we want to give you that answer with an evidence-based structure. With an easy way to remember this, and also enable you to operate at a high level with some solid understanding, or know where to go for even further solid understanding. So this is all based on this guideline. You guys will be very familiar with this organization, the ACC/AHA guidelines, American College of Cardiology, American Heart Association. The world uses this as a group. And now I'm going to hand over to Kaz to tell you a bit more about this guideline and some of the facets of it.
So look, guidelines are really important and they're really complicated, but realistically what we want to do is to take a really complicated document like this and then to filter down ideas that you can take away. So the reasons why guidelines are really important is because in anesthesia, as with many parts of medicine, but particularly in anesthesia, there's lots of different ways you can do it, and we've all got really strong opinions on what we think is right, and that's based on different pockets of evidence. But the best decision that you can make for your patients is one that's based on as much evidence as possible, and usually that takes the form of these general, these consensus clinical practice guidelines that are based on evidence. And expert evidence and expert opinion and consensus is always better than whatever you think is right, and sometimes what your consultant thinks is right. And it's always, I think, defendable, not only to, in a medical legal sense, but in kind of a moral, personal sense. You can always go home and go, I did what's best based on the best available evidence.
Yeah, nice. And just quickly, because there's going to be two of us, feel free, if you want to ask any questions in the chat, when one of us is speaking, the other will be monitoring the chat, and feel free to ask questions and we'll be able to give reasonably comprehensive answers.
Thanks, Lau. So this diagram essentially is the basis of all your decision making, but it's really complicated. There's lots of steps here, and trying to make your way through this decision tree when you're assessing patients is not really practical. But what Lahir has done really is to take this concept and to distill it down to a very simple structure that you can apply every day. And this is stuff that we use, every consultant uses, and every registrar uses in the exam. And it holds a lot of truth. Every anaesthetist loves morning coffee. So this stands for E. So the basic idea is, do you proceed with surgery or do you refer on to another specialty? So every is emergency. So is it emergency or is it not emergency? A is whether they have an active cardiac condition. L is the risk of the procedure. Is it a low risk procedure or a high risk procedure? M stands for METS, which is a measure of their functional status, which we'll talk about. And the final thing is C, which is will it change management? So we'll start off with E. So Dean, since you're first on our list here, what would you classify? Give me an example of an emergency surgery.
That could be a bowel perforation or any other sort of viscous perforation, really.
Yep, fantastic. Yeah. Jackie, do you want to give me another one?
Down here, a lot of rural roads, so usually it's car accidents.
Yeah, that's a great question. So big traumas, lots of big bleeding, any kind of, any implications or any hollow organ injury. Good. Noemi?
Yeah, no, just Naomi's fine.
Oh, sorry.
No, it's okay. I guess multivessel cardiac arrest as well, myocardial infarction. I emphasize multivessel because, PCIs can probably do the more minor ones, but, ultimately.
Yeah, fantastic. So those are all right and all on the money. So an emergency procedure generally is something where the patient will deteriorate if the treatment or intervention is delayed, or they will lose life or lose limb. So everything you've mentioned are kind of really exciting, really fancy, kind of big stuff. But even something like appendicitis classifies as emergency because the longer you wait, you can perforate, they can become septic, and they can become quite unwell.
Yep.
Next slide.
Sorry.
Good. So the rationale behind this is that if it's an emergency Caesar as well, Mackenzie, that's an excellent example. So the idea is, the point is that there's no time to thoroughly evaluate a patient, but even more so, there's no time to do anything about it. So what you try to do is, in the main situation is to optimize. So you optimize their organ system, you optimize their blood pressure, their cardiac function, hemodynamic stability, and their kind of volume status. Those are some simple things. You increase your monitoring. So this might mean you put in an art line instead of just having an automatic non-invasive blood pressure. This might mean you put in a central line to measure CVP. If you're doing cardiac surgery, it might mean you put a pulmonary artery catheter. And even things like BIS monitoring, which is a depth of anesthesia monitor, can allow you to reduce the amount of anesthesia used. So all these things are taken into consideration, and then fundamentally you crack on. So now we've done E, which is every. So what would, and then active is anaesthetist. So active cardiac condition. So what would be an example of an active cardiac condition? Is it Lynn?
Yeah, Lene is fine.
Hey.
Maybe like a myocardial infarction, something like that.
Fantastic. So, myocardial infarction within 60 days, or acute coronary syndrome. So even things like unstable angina could potentially classify as active cardiac disease. Bosco, can you think of another example?
Some sort of like arrhythmias, possibly.
Yeah, so arrhythmias, so SVTs, any sort of junctional rhythms, or any kind of aberrant kind of re-entrant arrhythmias. Good. Cameron, can you think of something else?
Maybe like acute decompensated heart failure or low ejection fraction.
Yeah, fantastic. That's a really applicable example as well. So decompensated heart failure, so someone is in fluid overload. Aortic dissection, definitely. So that would be an emergency in and of itself. So you'd want to manage that as well. Thanks, DRS, for saying that. And Emma.
Could there be something like pericarditis? Or myocarditis. Oh, someone just said that. Yeah.
They stole your thunder. No, exactly. Yeah, and then Mackenzie and tamponade as well. Yeah, so those are all excellent. So I think you guys have got most of what we had up here.
I'm just gonna next slide in a second.
That's all right.
Yeah, so do we get all those?
I think the valvular disease was the one we missed, the severe aortic stenosis, and then arrhythmias. We got almost all of it. Well done.
Beautiful. Sorry, I'm just gonna, just in case people miss this Zoom link. Did you guys get, sorry, just trying to put in like this, but did you guys get it? I'm just using a new platform. Did you guys get a Zoom link email, or did you get in the last couple of days? Give me a thumbs up if you did. Cool.
Yeah.
Excellent.
Are we having comments on the page?
Yeah, someone just sent an email. That's all right. Get back to this now.
It might be the people on Facebook who didn't use the link. This happened the other day as well, remember?
Oh, yeah, all good. Okay, back to it.
Cool. All right, beautiful. So we've done whether it's emergency or not. So every anaesthetist is there an active cardiac condition. And then what was the next one? Loves. Low risk surgery. So what would be a low risk surgery? Who are we up to? I think Emma, you get an answer even. Yeah, and then Lewis, tongue.
I have no idea about that. Sorry, but I have a guess. I guess
please.
Low risk surgery would be like any surgery that does not cause much bleeding or does not like compromise the airways a lot. Yeah,
amazing. That's really good. So can you think of an example of something like that? That, a very easy operation that the surgeons love doing every day?
Like some kind of debridements, like aspirations. And,
great.
Yeah.
Yeah, amazing. Those are all really good examples. So debridements, lancing, abscesses. Yep, fantastic. And then I think we've got colonoscopy from Stephen, cataracts. Yep, pretty much the definition of a low risk surgery. Skin flaps and grafts, yeah. So depending on the size and the extent of those, is definitely right as well. But you can also have kind of these like big, nasty, head and neck flaps, which are still big surgeries, but that's really good. And most
so,
from the dental surgery.
And it's almost like this thing that if you think that surgery has little more metabolic impact than just walking around, that's low risk surgery. So yeah, most of the time it'll be low cut or no cuts, so like small cuts or no cuts. PCI is an interesting one because it really has minimal intervention, but I guess people think of it as some kind of moderate risk procedure depending on the cardiac status of the patient. But yeah, you're right that it's got very little metabolic impact to have a PCI or any kind of endoscopic kind of surgery or interventional surgery. Excellent.
Fantastic. Those are all really good. So the next one was METs less than 4. Did you want to talk a bit about this, Lahir?
Yeah, absolutely. Hey, so metabolic equivalence, who's heard of that? Just chuck your hand up if you have. Beautiful. Hey, Cameron, what do you reckon? What do you know about METs? It's safe place. Feel free to get this wrong. It's all right.
I shouldn't put my hand up. I think from memory, like 4 METs is something like walking up a flight of stairs or something. So it's what you can do in terms of physical activity.
That's good. It's a measure of physical activity. So it's really useful because instead of just going, that person can run or jump or play tennis, this Duke's Activity Status Index has made it more of a science. And what they've realized is that the METs has it's got a very specific definition. It's the ratio of work of the metabolic rate to resting metabolic rate. So it's always compared to what it is like to just be sitting doing nothing. It's defined by this index, and I'll show you a link to that specific questionnaire that can help you. And it's actually got some really specific values, like 3.5 mils of oxygen per kilo per hour, so per minute, that's wrong type over there, or 250 mils per minute in a rough average person sitting quietly. That's your basal metabolic rate. That's your 1 MET. And you'll get asked this question a lot in anesthetics because, if you know how much oxygen is being consumed every minute at rest, that's roughly how much oxygen consumption you're going to have. And you can, calculate apneic times and a few other things based on that. So really interesting concept that you'll hear time and time again. And if you think about it, if you can't go more than 4 METs, 4 times resting, which is really, really easy to do, like literally it's stair climbing, walking at a specific kind of 5.6 kilometers an hour when they measure it, and a few other things. If you can't do that, then your body probably can't increase its metabolic work to heal some kind of major, operation or major laceration or something like that. So that's the way I think about it. 4 METs is very specific as a number that they've shown probably correlates with increased survival. Less than 4 METs capability means like decreased survival perioperatively. So that's a really good number. And often the question you'll find people asking is, can you climb up a flight of stairs without stopping? Can you walk 4 blocks? And they've actually defined all of those things as well. But I find stair climbing is probably the most useful thing. When you're asking these questions as a medical student or in your anesthetic assessment, you'll quickly realize that, that fit young 20-year-old can easily do that. But when you get the elderly patient with lots of comorbidities, they may not be able to do that. And your consultant will probably want you to find out exactly what they can do. So if they can't walk up a flight of stairs, can you do your gardening? Can you walk to the shops? How far are the shops away? Can you walk to your mailbox? How far is that roughly? You could even get the patient to literally walk up a flight of stairs with you from the pre-admission clinic just to see if their functional status. Any questions about that before I move on? All good, all good. This is a QR code to the DASI questionnaire on MD Calc, one of my favorite apps that I'd use, like one of maybe 3 or 4 apps that I'd use constantly. So check it out because you can literally go on there, ask those questions that I was talking about and tell your consultant, tell your supervisor, hey, look, I think the METs are approximately this based on the DASI questionnaire. That will impress your bosses so much on the anesthetic rotation because a lot of them won't even know about this app. So that's a really good tip for if you're on your anesthetic rotation. And feel free to screenshot that as well if you want to use it for later, but it's on MD Calc, which is an app and web-based function. Okay. Go for it.
I had a quick question, if that's all right.
Yeah, please do, Andrew.
When asking about the METs or their capability, over what sort of time frame are we interested in? Are we interested in the last couple of weeks or the last month or
Yeah,
longer?
so generally speaking, it's in recent memory. For example, if they say that they used to be able to run, and it was 10 years ago, obviously useless because they can't now. If it was even 2 weeks ago and something's happened, that also matters. Maybe it's 2 weeks ago and then they had a heart attack. It doesn't matter what happened that much weeks ago. You really want to know what their function is right now, because that's probably what matters. It's also a very inexact science. There's a lot of problems with doing this way, but it's just part of a whole bigger picture, and also very useful concept that you'll kind of go into your operations thinking about.
Thank you.
Thanks, a good question.
And also, if there was a acute change in their functional status, like that's really important, because that means even if they weren't diagnosed with an AMI or something, that there's been some sort of a trigger for them to decompensate. And often it things like heart failure. So that's a really important thing to elucidate. If they go, actually, now that you mention it, I used to run marathons, but now I can't walk down the road. A bit dramatic, but you know what I mean. And then finally, and this is something that I think is really important and really hard to conceptualize, particularly for, I guess, non-anaesthetists, is will testing change management. So what does this mean? So if someone comes in with asthma and they say, I take salbutamol every now and then, you could do RFTs, right? But then you go, well, what will the result of that actually affect? So can you optimize their underlying condition any better? Or will it change what we do perioperatively? Or will we have to defer the surgery and get them to start a new therapy? So, and this decision-making process is quite challenging, and it's something that you slowly layer on. And often it's something that we get asked by surgical teams a lot. So for example, if they have chest pain, reduced functional capacity, active chest pain, will getting an echo or an angio or a nuclear med scan of the heart affect either the operation, whether we deter it, whether we change the operation to something potentially that's non-invasive or interventional, or would they be a candidate to undergo PCI or coronary artery graft surgery prior to the operation happening? And this is really a collaborative decision, isn't it, Lahiru? Like, it's something that we take a lot of ownership in, but we do talk to the surgeons and the cardiologists.
Yeah, and I'm always cautious about this slide. Like, this slide came out when there's probably less minimally invasive procedures. There was less ability of PCI to do stuff. There's less, minimally invasive mitral valve and aortic valve operations. So if I was to tell you to almost always err on the side of testing and defer to testing, that'd probably be a really reasonable thing for me to tell you guys, because these days there's so many minimally invasive things that you could convince almost any patient that, hey, you could have your elective surgery straight away, but if we just did this little test, we could stratify a risk. If we did this little procedure, minimal recovery time, it's a chance that we're going to make you much healthier. Almost all elective surgery decisions and progress can be made better with testing and an intervention. This is very different in other countries and maybe in outback Australian and Indigenous communities, but definitely for most big city Australian practice, I would almost always defer to testing if I was not sure.
Every anaesthetist loves morning coffee, I believe.
Fantastic. And what do they stand for?
Emergency surgery,
yep.
Active cardiac condition.
Fantastic.
If the surgery is going to be low risk.
Perfect.
METs, so measure of activities, and coffee. We just did this.
Exactly the hard part. No, that was good. You got the copy. And once you get to that point, you've pretty much sorted everything out, and it's will testing change, see for change management. So yeah, every anaesthetist loves morning coffee. Really easy to remember. It's true. Part of my day is actually just figuring out which coffee orders to take for people. But hey, let's get into it. So again, I want this to be really practical. So let's practice some real life scenarios. So even as medical students or junior doctors, you can put this into practice completely accurately by doing this. So let's go through some scenarios. So the first one, 68-year-old non-STEMI 2 weeks prior, ongoing unstable angina. They've had a high-speed MVA, free fluid in the abdomen, and the surgeon now wants to proceed to theatre urgently. So now going through, every anaesthetist loves morning coffee. What do you reckon you need to do at this point? Now, there's a conundrum, right? You've got a procedure that needs to happen, and you've got unstable angina. What do you reckon, Dean?
Yeah, so sort of further to what some of the examples were before, it seems like this is an emergency, so I don't think we can afford to wait because that free fluid might be blood, so we obviously don't want someone to bleed out. We'd probably have to take the risk.
Exactly, it's that easy. You need to proceed. There's a few things you might do, like call cardiology and optimize and get hemoglobin back and prop up the blood pressure and get all that oxygen supply demand balance going. But either way you proceed, this is seriously emergent surgery. As I go through, definitely type in the chat if you got questions. Definitely ask out if you got questions. The next case, 78-year-old female, fractured NOF, multiple comorbidities, including ischemic heart disease, AF, unknown exercise tolerance, the usual kind of fractured NOF patient, and they're in pain and signs of fluid overload, and they're mentally, but they are mentally alert. Okay, so let's say they're not for palliation of any sort, and they are ready for a procedure. Oh, they need to have this procedure. What do you reckon? Just following that format, Jackie, what would you do?
She wouldn't need to be rushed because you could actually assess and correct the fluid overload probably first, but as long as the fracture's stable to a degree, as long as there's no cardiovascular loss with the fractured NOF, like depending on what she's done internally as well with that. And going from there, getting her breathing and her circulation stable, then taking her into theatre to correct it.
That's really good. So now this is a really good example of, this isn't emergency surgery, but it's definitely urgent surgery. So this is surgery that for most guidelines needs to happen within 48 hours, preferably 24 hours, because sitting on a fractured NOF without operating increases mortality regardless. So think about this. There's a sick patient, unknown exercise tolerance, and I'm now telling you, within 24 to 48 hours regardless, you're not going to be doing any testing, cardiac testing. You're literally going to get in there and treat what you can immediately, which is what Jackie said, like, signs of fluid overload. You can give some furosemide, medical team manages their heart failure, and you might want to replace a few other things like the HB. But yeah, you could fix some things like rapid AF, heart failure, sepsis, blood loss in a small time frame, but it's urgent surgery, therefore you proceed. It's in the emergency banner, but it's urgent as defined by a time frame of within 48 hours. Okay, next scenario. Okay, so 70-year-old male, PR bleeding, secondary colon carcinoma, type 2 diabetic, cholesterol, hypertension, unknown exercise tolerance. What do you reckon? How would you kind of classify this and work down the algorithm, Naomi?
Yeah, I'd say that there's it's a little bit lower down than the previous one as well, but it's still like fairly urgent. So I would definitely want to do more testing at this stage. I think you'd have room to do testing just to see the degree of what's going on, because if he's got colon carcinoma, it's obvious that PR bleeding will probably be associated with that. So maybe go up with a colonoscopy, a scope, check out what's going on, and then you can decide from then on to see how urgent it is, whether he needs a colectomy or hemicolectomy or what the situation is.
Yeah, good. Let's say they do need a colectomy, and you've highlighted a really good thing, that it's not emergency, it's not urgent, and this is what they'd call time sensitive. Roughly, you've got to do it within the week, so like say 2-week mark. And because you've highlighted that, it still falls under the emergency category in the framework, but you can only fix certain things in that 2-week period. So most people would do limited testing investigations. Again, a bit of a chat about, with your surgeon and with the medics about what you do, but this falls under the most likely we proceed and we optimize what we can in a short time frame. But they're not going for CAGs, they're not going for platelet therapy. They're not going for stents and then on dual antiplatelets. So this is tricky. What can be optimized in the 2 weeks prior? And then, can they really have CAGs? Probably not. Maybe they can have stents, but then you need anticoagulation. And now they've really got this carcinoma that's potentially invasive that needs to be done. So taking this with and understanding that this could be pretty complex, if we were just to simplify this as a rule, cancer surgery that's time sensitive, you crack on as well, and you do what you can in 2 weeks. CAGs are coronary artery graft surgery, which is, stenotomy and bypass graft, so cardiac bypass surgery. Okay, so these are all emergency, urgent, or time-sensitive operations. They need a nuanced discussion, and they're very tricky, but generally speaking, you crack on. So now we go to the next one. So that was emergency or every. The next one is anaesthetist. So every anaesthetist loves morning coffee. A stands for active cardiac conditions. And we have this situation, a 60-year-old lady for a lap chole, now with chronic AF. Chronic AF now with a rate at 140, but with no symptoms from that. So let's say the blood pressure and everything's pretty stable in spite of the heart rate. Using the algorithm, what would you do? Cameron McGrath, what do you reckon?
So it's not emergency at this stage. It's not a low risk procedure. She doesn't have a cardiac, well, she's got a chronic cardiac condition, but not an active cardiac condition. So I guess see what her mets are.
Actually, no, and so because it's AF, it's chronic, but the rate is 140. So which part of active could that come under?
Oh, like a SVT or?
Yeah, well, I mean, it is just rapid AF,
sorry. Yeah.
But it's like the too fast rapid AF. Now you've highlighted an interesting thing. I've told you it's chronic, so that's kind of made people think, oh well, it's chronic. They've already had it, but AF can be unstable or unstable, and as soon as it's too fast or too slow, just like heart block is too slow and SVT is generally fast or too fast, this now falls into the active condition, but is not within the normal heart rate parameters. So that's good. Highlight that fact, and then you've got to modify it. You've got to somehow bring the heart rate back into control and then proceed. But at this point right now, it's active, therefore you refer. So elective surgery, not emergency. So you go to the next one. It's an active cardiac condition because it falls under that banner. So you refer and you scale up to refer up to your consultant. Let's keep going. So this patient here, 60-year-old female for a laparotomy for incisional hernia repair. The patient has rheumatoid arthritis and you notice a systolic murmur. So next person along, Lewis Tung, what do you reckon? Just following your format, what's going on?
Yep, so surely this is not emergency surgery, it's an elective. And yeah, we go to see if this is acute condition, like acute cardiac condition. If it is systolic murmur, I'm not sure if it is quite.
Yeah. So what could it be? So you're exactly right. You've got the clue, which is systolic murmur. So what kind of systolic murmur is an active cardiac condition? This may be something you've heard.
Someone said in the chat it's like aortic stenosis or mitral regurg. That I would know that it's a systolic murmur, but I don't know the significance of it.
Perfect. And so exactly, I think someone said it's often aortic stenosis or it's mitral regurg. Those are the common pathologies. Get this, if it's mitral regurg, it's rarely ever going to be an active cardiac condition alone unless it causes some serious heart failure. But aortic stenosis that's severe or symptomatic is an active cardiac condition. So aortic stenosis, bad. Mitral regurg, usually really good under anesthesia, not a problem. So as an anaesthetist, I see aortic stenosis that's moderate to severe or severe. I'm like, okay, I better really sort this out. But if it is mitral regurg, even severe mitral regurg is very tolerant under anesthesia.
Yep, so the management here would be find out if the patient have either stenosis or regurg.
Exactly. How could you do that?
I guess we can do an echo.
Perfect. Bedside echo can easily figure that out. Also, you might look at other criteria. So if you've ever read Tally O'Connor in detail, they've got a whole bunch of things that are markers of severity of aortic stenosis. If you really want to impress, you say, this is a slow rising plateau pulse, or it's got, some kind of heave there or a really loud sound. And you say this combination of symptoms equals probably severe or could be severe. Therefore, I really want an echo. But either one of those is a good framework. Often that's a contentious topic. Does this mean that only if symptomatic, aortic stenosis is worth managing? Otherwise, just leave it? Yeah, so the ACC-AHA has a whole panel of valve guidelines. And look, I've got to recall it correctly. There's the class 1 recommendations for surgery is symptomatic severe aortic stenosis. It may be severe as well, or moderate to severe, but having other CAGs along with it. So yeah, it gets very specific, but essentially severe symptomatic aortic stenosis needs to be managed. Okay, 50-year-old male for inguinal hernia repair with trifascicular block with multiple fainting episodes. Again, using the format. Andrew Ridings, if you're around.
I am.
Go for it.
Again, I'd start with this is not a urgent or emergency surgery.
Perfect.
I actually haven't heard of a trivascular block. Is that like three or more cardiac veins?
Yeah, it's right bundle branch block with a left axis deviation. So you've got and a first degree heart block.
Okay.
So essentially, it's a really high grade heart block, and it's got certain risk with it. So usually, its trifascicular block is stable in itself, but the fact that I've said multiple fainting episodes means something. What do you reckon? Just off the cuff.
Yeah. So active heart cardiac issue. So heart block. Yeah. So maybe third degree or second degree heart block. With syncope.
Exactly. So I've given you a complex trifascicular block, which is actually not a active cardiac condition, but the fact that I've said multiple fainting episodes means what someone said in the chat. Essentially, this is going into third degree heart block. So you want to be really worried about this. Again, as a medical student, anytime you see a really high degree, like a trifascicular or any second degree or above heart block, you're worried about that. So yeah, at that point, it's elective and you refer. So again, we've done emergency. Now we've done active cardiac conditions. Every anaesthetist, and these are all active cardiac conditions, they have high mortality by the nature they're active and serious. So you postpone and refer. Again, at any point, ask any questions about this. But you can see that there's a really solid, logical way that we're handling this that makes a lot of intuitive sense regardless of this guideline. So let's go for this one. 78-year-old female, recent echo showing moderate aortic stenosis. So it's not severe, for cataract surgery. And this patient's unable to walk up a flight of stairs due to arthritis. Next person along, I might ask Kaylee Tang. I know your camera's not on, but if you're comfortable answering, we can help you through it.
Yeah, so I think just looking through the guidelines, it's not emergency.
Yes, cataract is totally elective.
Yeah. I think moderate aortic stenosis. I guess I'm not sure if that's I guess that's not severe, but I'm not sure if they're symptomatic.
Yeah, good. Let's say they're not symptomatic, and it's definitely not severe, so it's moderate.
In that case, I don't think that's an active cardiac condition then.
Perfect.
So the next step is a low risk procedure, which I think I remember cataracts being on there.
It is, yes. Very little incision, totally low risk.
So I guess perhaps not something that you do urgently.
Yeah, so what do you want to do? Do you want to postpone or do you want to refer this? Sorry, do you want to proceed with the surgery, even though this patient can't walk up a flight of stairs, or do you want to postpone for testing?
I think postpone.
Now, what do the guidelines say? By the way, this is what's beautiful about this. Sorry, I better get this proper up here. This is what's not intuitive. And this is really good.
Okay.
Yeah, right. So this patient had elective surgery, so you move down. It wasn't active, so you move down. And then, so because it's low risk surgery, the patient could be potentially pretty unwell on paper, but not unwell enough that it's an active condition. And the surgery is so low risk that it's barely more than walking. You know, it's barely more metabolic insult than walking. And that's why it's okay for even this patient to proceed with the surgery. And it might sound really unusual, but I do probably, hundreds of cataracts, about 1,000 cataract operations a year. And this is the very typical patient, just to give you some grounding in that. So elective surgery, no active conditions, low risk, therefore proceed. How about this one?
Lahiru,
yeah,
just a question on that. So so most cataracts are done under local anesthesia or kind of eye drops. If for some reason this patient needed a general anesthetic and you were in, say, a smaller regional hospital or a day hospital in the city, would that change your decision making?
Yeah, that's a really good question. That gets complicated because as soon as you have to do it in a small hospital without adequate resources, then you'll start to have to do higher intensity anesthetics. For example, you might have to put an arterial line and you'll have to have staff that are capable of managing these things. So if this was a day hospital without much support, you probably would want to ideally, like this can be done as a GA with very low mortality, but the hospital needs to be set up for it. So that's a bit more of a complex situational environmental question than the patients, than the patient themselves. That's a really good question.
And we just have a question to the chat, Lahiri. So the question from CL was, what if it was cataracts then, but severe COPD instead?
That's a really good question. I'm going to answer that at the very end of the talk, actually. So I'm going to leave it for that, but definitely a good question I'll get into. Okay, 60-year-old male for a lap collie, walks 1 kilometer every day. Actually, you know what? I will answer that now because you've asked, CL. So you could do a similar thing, right? This is not emergency surgery. If the severe COPD was not absolutely active, there is a good argument that you could continue with the cataract operation because it's not going to be, let's say they were able to have this anesthetic without a general anesthetic with topical drops and they weren't coughing so the surgeon didn't have a really ridiculous moving field, then it would be able to be done. I've had plenty of patients with severe COPD. We just give them lots of inhaled corticosteroids and Ventolin, make sure that they're stable and not having an infective exacerbation, and we get them through the operation with just topical drops and a bit of sedation. So definitely very possible to go ahead. If they were having an active exacerbation of this, you'd probably postpone. And we can, what I'll talk about at the end of this is the fact that you can use this framework for almost any conditions, not just cardiac conditions. So that's a really good kind of thing to bring up. Actually, CL, because you asked a very good question, you get to talk about this one. So 60-year-old male for lap collie, walks 1 kilometer every day, no past history. Use the format and then tell me what you want to do.
Yeah, so just having a look at it, doesn't seem like it's an emergent surgery, just a a lap collie.
True.
He's able to walk 1 kilometer every day. So I think that's pretty good. He's got no past medical history or anything. So I feel like given those situations, you can just proceed with surgery as suitable.
Beautiful. And to step through it, so you said it's elective surgery. What's A stand for, and what's your assessment?
Yeah, so the active cardiac condition. So ideally, you just get a bit of a history about that, but based on what is written there, there's no past medical history. So I'm guessing that's all good.
Yep.
In terms of it being low risk, because how do I say, like a lap collie, you do make quite a big incision and things like that to go in. Would that still be considered as like a lower?
It's safe for you to say it's not low risk just because it's a intracavity surgery.
Yeah.
But then as techniques get more and more, as they get better, incisions get smaller, surgeons get quicker. This is slowly progressing into lower and lower risk. But just for now, it's far safer for you to say, this is not low risk surgery, therefore moving to the next thing, which is what letter and what does it stand for?
Yeah, the METS thing. And so you ask a bit of history about that, like climbing flights of stairs or whatever, but she can walk 1 kilometer every day. So that seems pretty good.
Yeah.
And yeah, there's nothing really to do for testing of changing or management and things.
So as soon as they can walk formats, you don't even have to go to see, you just go straight to surgery.
Cool. Yeah.
Beautiful.
Just a question. So you said like with the low risk, what is the what is the threshold before you say something is low or high risk again?
Yeah, so it's easy for me to tell what's included. If you think of anything that is a day procedure, so lumps and bumps, small skin excisions, any kind of scopes, ureteroscopes, colonoscopes, gastroscopes, there's no cutting to be done really, or minimal cutting. Cataract operations, tiny cut. There's really no metabolic requirement of the body to heal stuff. And that's what makes the surgery safe if it's low risk. So as soon as we get into any kind of intracavity surgery like lap collies and anything more major, then we start thinking. So that's probably a good scopes, lumps and bumps, cataracts. That's a really good summary. Anything that's a day surgery. Anything you're not sure about that falls outside of that, err on the side of this is not low risk.
Cool. Well, thanks, Leo.
Nice. Okay, let's go to this one. 60-year-old male, total hip replacement, AF 70. AF at a rate of 70, that is. Cholesterol, hypertension, obese, stays in bed most days, walks to the lounge to watch TV. What do you reckon you'd do? I might ask another person, Huiseong, H-W-I-S-E-O-N-G. I know you don't have your camera on, but if you'd like to answer, that'd be great.
Yeah, so
just follow the format and yeah.
So as per the format, I don't really think this is emergency. And
yep, it's not emergency.
AF it's yeah. So as per AF 70, as you have mentioned earlier, that AF with Brady can be often severe with hypertension and high cholesterol.
So is this an active cardiac condition, do you reckon? Is it too fast or is it too slow at a rate of 70?
The rate itself is good, but with AF, I believe it's a little slow.
Oh no, this is fine, yeah. So often we'll control patients with AF to a rate of around 60, 70. So that's totally fine. Yep, keep going. So it's not an active, there's no active condition here. What's the next one?
Yeah, so risk. So sorry, so what was THR again? Total hip replacement. Yeah,
sorry,
okay.
Total, so
yeah, sure. So I believe, I don't think I can call it low risk.
Exactly, it's not low risk. And so then the next question is, what?
More than 4 meds?
Yeah, what do you reckon? What information would you like to check whether they can do more than 4 meds?
Yeah, in first place, I want to know if he's active and physically fit enough, but with him staying at his bed for the most days and just watching TV all day. So I don't really think he meets the criteria there.
Yeah, good. And that's something you can explore. So just get this, it's elective surgery. There's no active cardiac conditions when you ask questions on history. It's not low risk. It's a major operation, total hip replacement, and the mets are unknown. So you're not sure. If you end up asking enough questions to find out the mets are actually pretty good, that actually they haven't told you enough, then you could proceed. But if they're unknown or poor, then you want to consider referring. So always err on the side of referring to get some more information, just in case, because testing might change this management. So I would proceed if the mets were good, but I wouldn't if the mets were bad or less than 4. Okay. Look, the last case, I'm just going to, this is where it gets to the pointy end of things. So 65-year-old female, total knee replacement. You've got a whole bunch of bad stuff there. Ischemic heart disease, diabetic, NYHA2 heart failure, transient ischemic attack, hypertension, cholesterol, asthma, and they've got poor exercise tolerance and they need help with most of their activities of daily living. So as you can all see, this is the pointy end of things, right? It's elective surgery, total knee replacement. There's no active conditions that I've mentioned here. I've just mentioned lots of badness, but nothing's active. It's all kind of stable. It's not low risk surgery. And this patient really can't do 4 mets based on what we've found there. And so because they've got all of these cardiac risk factors and testing might change management, what do? I'd refer to cardiology, I'd refer to the medics and get my stress test to check whether they've got potential reversible ischemia on the echo or the stress test, and maybe they go for angio, and either that clears it up and says this patient's fine for surgery, or we can risk stratify and find out some information. I've just got some good questions. Given the risk of ischemic stroke post-TIA, is that the equivalent? Yes, so that's a good question. If the TIA happened within the new guidelines say within the last 60 to 90 days, then you would postpone elective surgery. And there's, again, absolute guidelines on that now, showing massive Danish studies showing that mortality from stroke decreases after 60 to 90 days. So you'd want to wait longer than we used to wait. Under what circumstances would one order an ECG? Yeah, good question. So actually, that's a big question. Send me an email, Andrew, and I'll give you some information about that. So that's the format, right? So to recap, the mnemonic is every anaesthetist really loves morning coffee. Very easy framework to practically apply a really complex area of medicine. But as a medical student, as a junior doctor, I need you to have this framework because it's so common that you'll come up against this circumstance. And yeah, we want to kind of give you this as a practical thing. So what can you do as an intern resident on the wards? Does anesthesia need to know preoperative, and why not? So, we want you to be able to ask your surgical interns and find out the rationale behind a lot of their choices. And then also know that as much as I've taught you these really good frameworks, sometimes you just have to refer to anesthesia regardless of the guideline because they seem high risk. And that's totally fine as well. Even though this guideline allows you to make some pretty big decisions, as a junior doctor, you want to be able to make a decision or suggest a decision, but also realize that I will refer high-risk patients, sick hearts, sick lungs, big operations, and any facial features that are not quite right, or NQR, because that equals bad airway issues that we need to plan for. So I hope that makes sense. This guideline will give you the tools to make very reasonable decisions in most circumstances, but regardless, if the patient's high risk, definitely refer to anesthesia. Now, feel free to take a screenshot of that or take a photo of that. Obviously I'll put this up on YouTube for you guys, but I also wanted, before we head off and give you some time for questions, I wanted to mention about the fact that we've talked about cardiac disease, but really this framework I apply for almost any pathology, whether it's respiratory, renal, liver, whatever it is. So if you think about a patient with active wheezing, what do? Well, elective hernia is elective, but it's an active condition of the patient suddenly wheezing. Therefore, I postpone or I try to treat the wheezing with, salbutamol and ipratropium bromide until I get rid of it. If I then get a patient with well-controlled but bad asthma for a lipoma excision, lipomas are very small cuts. Therefore, this is probably safe. So again, the framework is it's elective. There's no active conditions. It's just bad asthma, but it's optimized. And the procedure is low risk, therefore I can proceed. Elective coli, known COPD, same thing. Let's say they've had multiple exacerbations, just like we talked about. What do? It's an active condition, even though it's elective. So it's elective, but active, therefore I postpone and treat. Weeks later, they come back in there, they have well-controlled COPD with good exercise tolerance, elective surgery, no active conditions. It's a lap coli, so not low risk, but they have, they can do that good exercise tolerance. They have greater than 4 METs, therefore we proceed. So now let's use the same algorithm for any non-cardiac disease, and that'll still make sense. So emergency proceed. If it's active ERT, asthma, COPD, acute renal failure, acute liver failure, whatever it is, that needs referral. Low risk, proceed. Greater than 4 METs, proceed. Will testing, change management. Think about all the tests for each of those, each organ system that you can do. So for lungs, spirometry, maybe CPX testing. For liver, you might have a whole bunch of gastroenterology specific investigations like, liver scans and, gastroscopes and other functional tests. Hey, so that's almost the hour. Anyone have any questions for either me or Kaz? Does this framework change if the position of the patient is not conventional? Yeah, absolutely. So even though this guideline is pretty straightforward, there's going to be lots of subtleties. Like we mentioned, if the hospital is very small and unable to cope with high risk patients or certain advanced monitoring, absolutely. If the patient has a very specific issue, like a risk of air embolism, and if it's a high risk procedure, a very nuanced procedure, that will definitely require an extra conversation. So yeah, the framework does have, the framework works for 99% of the time, and 1%, if it's an unusual situation, you'll definitely have to think outside the framework. NQR stands for not quite right. So yeah, if the airway, if the facial features are NQR or not quite right, chances are the airway is not quite right. Okay, so we'll stay around for another couple of minutes. Anyone feel free to ask ask questions. So again, check out. So here's a summary. The ACCHA guidelines gives you an evidence-based approach to the cardiac patient. This is really useful stuff to know when to proceed or postpone, even as a medical student or junior doctor, and you can have any approach to any disease. So yeah, all my trainees learn this. Every anaesthetist loves morning coffee. It's true, and it works for this. Now, often people, I really want you guys to give us feedback on how we can make these sessions better. This is only the second session we've run for medical students outside of, Melbourne University. So please evaluate us, get your phones out and, use a QR code to give us some feedback. That'd be really useful for us. Does that count as an active condition is the question, especially in patients with concomitant chronic renal or liver issues?
I think that's in relation to infection. There was a comment prior to that.
Okay.
What about infection? Does that count as an active condition?
Oh, yeah. Yeah, so if something is generally speaking, an acute infection will be an active condition. COPD is an example. Sometimes infections are very local and they're not too much of an issue. And other times, if you're implanting metal, like a total knee replacement or even a cataract, you don't want infection anywhere because metal can have infection just seed into it. This is the Medical Student's Guide to Anaesthesia, so I'm trying to make it make a full curriculum for you guys, and I'll keep adding to this. So feel free to sign up if you're keen on that. And all the other courses we run, you'll find on my website, which is anaesthesiacollective.com. So more useful lectures, again, the med student series there, and then the junior doctor series, which will be much more relevant when you're about to do an anesthetic rotation, especially as a junior doctor. That's on the other side. Yeah, these really good questions. A lot of the fine detail stuff is definitely nuanced, and you'll get a bit of variability. But this will, I'd honestly say 99% of the time this works very well. Thanks, guys. Yeah, we've got a lecture probably coming up in a month's time or so, and hope to see you guys there.
Thank you very much.
Thanks.
Thank you.
Thank you. It was fantastic.
Thank you.